Well, good to see you all. Erin and I go a long way back, and she's a great resource for you guys too. I'm going to be I'm a neonatologist, so my discussion is mainly going to focus on neonatal intensive care type medicine, but it applies to all aspects of nursing. Erin did a lot of intensive care stuff, so she's really a good resource for you guys if you're interested in those fields. And I actually will put a plug in for intensive care. There's something about being an intensive care nurse that you're kind of in a community. You don't get floated around very often. That's really unusual. You get around a group of people that you know really well, babies you know really well, and then you get very attached to parents, so you're not floating so much. So there's a sense of community about that. And so and even with the physicians as well, I really count all the nurses I work with as friends because you're there with each other all day long. So just a little plug for that. I'm going to talk about grief and loss, and I don't want this to be a really dry academic lecture. There's all sorts of things about the 5 ways that people grieve and things like that. I'm going to talk about some of those things, but what I really want to do is give more real life type situations and some thoughts of other people that aren't necessarily in medicine, because I think that they have some insight that scientific minded medicine people don't. And then in the process, you'll hear a little bit about my journey as well. But like I said, I'm a neonatologist, and right now I'm actually working primarily at Holy Family and Valley Hospital. I'm doing their newborn nursery, and then Holy Family also has a level 2 nursery. But the group that I'm a part of also does Sacred Heart and Deaconess, the intensive care nurseries there. So let's talk about grief and loss. First of all, this is me. I was just a mere lad in Texas. That's where I was born. You can see how fancy I dressed back then. I'm a little bit dismayed that my parents dressed me that way, but this is just to give you some background of where I came from, because it may ring bells, it may have connections with you. But I went to undergraduate at Pacific Lutheran in Tacoma, so I was a Lute. And then I went to medical school at Creighton University in Omaha, Nebraska, which gave me a nice exposure to the Midwest, but it also told me I did not want to live in the Midwest. Loved the people, hated the weather. So then, when I applied to residency programs, I just looked on the West Coast, and I ended up at University of California, Irvine. And oddly enough, their mascot's an anteater. But I was at University of California, Irvine for my pediatric residency. Then I did my neonatal fellowship at Stanford. And then from Stanford, I was there for probably about 7 years. And then from there, I ended up in Spokane. So I did some research, basic science research at Stanford, as well as some attending in their neonatal unit there. This last one is I actually left medicine for 8 years, and I went and got a theology degree at Whitworth. So that's why I throw that up there too, and you'll hear a little bit more about that as well. So I have been able to experience some of the Spokane fine universities too, and it was a great experience there. Ended up in neonatology. When I was before I got into medical school, I volunteered at a retirement home, and I loved working with old people. That was just really, really cool, and I think you guys have just recently come through a rotation like that. It is hard work. It's emotionally exhausting, but it was amazing. But where did I end up? I ended up on the other end of the spectrum. I never expected. I thought I was going to go into geriatrics, but I ended up in neonatal medicine. So this is just one of those patients, and you can see they're pretty darn small. Grief and loss. You can't divorce the spiritual aspect of grief and loss. Now, some people are going to have a spiritual life, some are not. Most people do. But it's something that's very intertwined when you're talking about grief and loss. So it's easy for us as nurses and physicians to just talk about the medical scientific side. But there's a side that we don't see, some people are uncomfortable with, but that is very much real, although it's not seen. So really for us, as doctors and nurses, we're caring for these patients. Most of the time we're dealing with the physical problems, the diseases that we're trying to combat. But we have to recognize that there's also a spiritual battle in a sense going on too, and that your patient is thinking spiritual things, especially if you're talking about people dying, end-of-life issues, things like that. So we are in quite a unique position. It's a battle on both sides. So we just need to be aware of that. So physical disease, but yet spiritual turmoil. I'm going to give you a couple scenarios of patients that I dealt with in the neonatal unit. And these are patients that are babies that were very sick, had significant problems, and how the families dealt with the grief and loss. And it's interesting because no two families do it exactly the same, but there's some general categories and general ways that they respond. So I'm just going to go through a couple cases just to kind of show you what happened and what the situation that we were faced with. First one, term baby, little girl born in Othello, Washington. The pregnancy was uncomplicated, but after delivery, the baby required resuscitation. So it was kind of unexpected, and they didn't really know what was going on, and the baby was not responding to normal resuscitation. So the baby was transferred to Spokane for treatment and evaluation. What we found out was that the baby had a progressive neuromuscular disease, so basically just wasting the muscles, respiratory muscles included, and so the baby was ventilator dependent. Could not live without the ventilator. So there was no chance of long-term survival in this baby. The parents were both 18 years old. They were unmarried. They weren't very good communicators. They weren't accepting of the diagnosis, despite the fact that we went over it multiple times with them. The parents withdrew, so just withdrew emotionally from the situation, spent much more time in Othello than they did actually with their baby in Spokane. And they didn't visit frequently. And when they did visit, they visited at night because they knew they wouldn't have to talk to a physician. So they were trying to avoid us because we wanted to explain to them what was going on. They weren't willing to accept it. The nursing staff was uncomfortable because they're caring for this baby that they know is going to die. And when you're in an intensive care nursery, you do a lot of things that are not pleasant to babies. And that's okay if you know the long-term survival is good. But in a situation where you know the baby's going to die, it just seems like unnecessary suffering that you're imposing. And so it's difficult for the nursing staff. So they were uncomfortable. It's not that they didn't love this baby or care for this baby, but they felt that they were causing more harm than good. And the parents were not willing to discuss the discontinuation of intensive care. After several months, the baby had a cardiorespiratory compromise and died. I was on that night, called the parents, told them what was going on, and they tried to get there, but they weren't there when the baby died. The parents were very angry. They were just angry. There was nothing that we could have done or anything like that. So this is not the way you want to end one of these kind of situations, but that's the way it was. Here's another scenario. The term female was with a scheduled delivery in Spokane, because it had a prenatally diagnosed heart condition, which I'll tell you about in a second, called hypoplastic left heart, which basically means that the left heart is not working. So it's a very serious diagnosis. The parents met with perinatologists, cardiologists, and neonatologists. All of us met with them before the baby even delivered. So they knew what to expect. They knew our roles. The baby was delivered, admitted to the NICU, placed on a prostaglandin drip, which is something that needs to keep a vessel outside the heart open so that they can survive for the short term. And then the baby was evaluated. So hypoplastic left heart, just so you have an understanding, if this is a normal heart right here, in hypoplastic left heart, there's really no left ventricle. And if you remember your anatomy, left ventricle is pretty darn important. And because of that, we're going to require some serious surgery. This vessel here, this is called the ductus arteriosus here. You can see it's not present in the normal heart because it closes right after birth. But this needs to remain open. This is why we give prostaglandin, because that keeps this open. Because if you can't pump blood through the left ventricle, that means that nothing gets into your aorta, which means nothing gets to the rest of the body, which means death. So, but fascinatingly enough, in the fetus, because this vessel is open, if it stays open, blood that goes from the right ventricle can feed the lungs and also the aorta. So you put them on this medication to keep this vessel open until such time as you can do surgery. But long term, that's going to close. And so you're going to have to do something about that. So it's a very serious heart condition. Evaluation revealed the baby was not a candidate for palliative surgery because there's a stepwise surgery that you can go through. The baby wasn't a candidate for that. So the only option was a transplant. The transplant option was at Stanford. But they wanted us to evaluate the baby before the baby went. The baby developed increasing heart failure, started to be on a ventilator. Then the baby developed seizures, and it turned out the baby had multiple strokes on the MRI. So the neurological prognosis was very poor. And now this baby was no longer a transplant candidate either. So there was nothing more to be done. Parents had been married for 5 years. They had one other child. Parents were very involved in their faith in church, and they prayerfully considered all options. They initially wanted the transplant, but then once they realized that now the little girl didn't qualify anymore, they said, okay, we're going to withdraw support. So the parents had all family and friends. It was a nice thing in that it was controlled because we could control this. So they brought in as many family and friends as they wanted to. The baby was removed from the ventilator. Parents held. The baby died after about 2 hours. The parents were very grateful for all the support, sent a card to us. Just, it was an amazing family. So if a death experience can be good, this was a good death experience. And it was really because of this patient, these parents, their faith background. But now this next one also has a faith background, but it was actually more problematic. This one's a term male delivered by emergency C-section in Moses Lake. So there was fetal distress. So something was going on inside the womb that required an emergency delivery. The baby required CPR, code medications, a ventilator, had very low APGAR scores. These are physiological measures of how a baby's adapting after birth, 10 being the best, 0 being the worst. So this baby is starting out very poorly. pH of 6.8, you should have a pH around 7.4, 7.3. 7.2s after birth are fine, but 6.8 is really low. The baby had seizures, was transported to Spokane. The baby was diagnosed with severe hypoxic ischemic encephalopathy, so severe deprivation of the brain, deprivation of oxygen to the brain. So this baby had poor respiratory drive, so it was dependent on the ventilator. Because of the neurological problems, the baby couldn't swallow or had no gag reflex, so it would accumulate secretions and then would have to be suctioned frequently, and had a very poor prognosis. The nurses, once again, very uncomfortable caring for this baby because there's nothing that they could do, and they knew that the situation was futile, and all they were doing was causing a lot of pain and distress. The parents were in their mid-30s. They were married, Hispanic. They only spoke Spanish. A very religious family. But the parents were awaiting God's miracle, and so they would not entertain removing life support at all because they said, well, God's going to do a miracle. Despite numerous conferences, the baby, and we telling them about the ventilator dependence and the severe neurological handicap, they still wanted everything done. The difference was they were there all the time. They cared for their baby. So as opposed to that first couple who basically just kind of left and didn't really come back because they didn't want to see their baby, this family was very involved. But again, they're waiting for a miracle from God. Baby received a gastrostomy feeding tube, a tracheostomy. The parents were mostly annoyed because we had nothing but bad things to say to them. The baby was transferred to a long-term care facility in Tacoma. The baby was ventilator dependent, but there the baby died of a respiratory arrest. So we didn't really communicate with the family much after that. But again, an involved family, a religious family, waiting for a miracle in a situation that we feel is futile, yet they continue to press for us to do everything, making us uncomfortable. So these are 3 situations where it's a bad situation and the parents are dealing with many issues. And how do they deal with it? How do they make the proper decisions? We'll talk a little bit more about that later. Anybody have any other thoughts about this in the sense maybe your own experiences with patients, experience with family? Because it comes in all sorts of different forms. I didn't know if you guys, last time I gave this talk, there were some people that brought up some interesting family situations. Any thoughts? Yeah.
My sister had her first pregnancy. She went differently.
Yeah. And that's huge because you are going to be an advocate for patients going through similar circumstances. And we'll talk about that because it's really an interesting phenomenon. But I think there are many of you that you went into nursing for reasons similar to that. You wanted to help somebody, or a nurse had had been really kind to a parent or grandparent that was dying or something like that. So I think those are all. So let's kind of explore this a little bit more. Let me just ask you a question. Conventional medicine versus alternative medicine. The reason I throw this up here is because conventional medicine used to be the only game in town, really. That was it. Then alternative medicine started cropping up. Why? And to now I would say it's quite popular. And alternative medicine, I'm not talking about just voodoo or anything like that, but chiropractic, which is becoming more mainstream, osteopathy, things like that. So I'm not demeaning any of those, but those are just alternative ways of providing medical care. Why do you think that is?
Well, personally, I think that it's because a lot of conventional medicine isn't working. Like, we're in the year 2018 of things because none of us are the same. Our body's going to react differently to everything. So.
Exactly. Excellent. Any other thoughts? I'd throw out another one. People that practice alternative medicine spend time with their patients. And I'm speaking as a conventional medicine guy. And I think it's true. I think conventional medicine is geared to see 10 patients every hour, and it's boom, boom, boom. What's your problem? Here's your drugs. What's your problem? And I'm painting with a pretty broad brushstroke there. And I know most of the physicians are actually frustrated with it because some of it's driven by the practice and the need to pay employees and things like that as well. But most alternative care people spend time. They know about your uncle and your aunt and problems at home and other issues that may be tangential to your actual disease. So they actually want to go someplace where somebody will actually talk to them about their disease. So I would throw that one out as well. And so the reason I bring this up is because I think we need to remember that we're just not pill pushers. We are actually trying to heal other aspects of their life. I think a lot of alternative medicines talk about the power of positive thinking and all that, and there's data to suggest that happier people get sick less and things like that. So there's probably a powerful emotional aspect to it. So why not use that to our advantage as well? Conventional medicine just doesn't always allow that to happen. So I throw that out there because I want us to think about that too. Not that we're going to practice alternative medicine in these situations, but to think there are other aspects of a patient's life I need to address besides just pushing medications. And I mentioned before that we have this spiritual, physical thing, and it's something just to be aware of. And I don't care where you are in your own spiritual walks, but you need to recognize that your patients are probably going to have some spiritual understanding of what happens after death. Roughly, in at least America, roughly 90% believe in a God of some sort or another. 72% believe in heaven, 58% believe in hell, 77% believe in angels. So it's very common for them to think in those terms when they're thinking about disease. When science fails and a patient dies, we're confronted with a new dynamic. The questions of purpose, God's will, heaven and hell, guilt, and compassion arise. So are we prepared to answer those? And so this is probably in many ways this talk is going to be more about just encouraging you guys to think about those things because you may be asked those questions. Not that you're going to have specific answers, but your journey through that is going to be important. But recognize that you may get those questions. So here's really what it comes down to. Last heartbeat, what's next? Again, the way you think spiritually is going to affect the way you answer that question. Are you just dead? Are you just worm food? Or, in the case of babies, becoming angels in heaven or whatever. Is there an afterlife? Is there not an afterlife? And that's going to affect the way you look at death as well. So it's just something for you guys to think about. And again, you don't have to have the answer to all this, but the fact that you've thought about it a little bit is going to make you a much better caretaker for the family. We've already talked about this a little bit in some of the examples you gave. Grief and loss can be acute or it can be anticipatory. So with acute, like the SIDS and things like that, it's sudden. There's no preparation and it's unpredictable. You don't know how that family is going to react. You don't know how you're going to react. And then there's the anticipatory, which are the ones that I talked about, where we really had time to try to sort some of those details out. So each situation is going to be a little bit different. Life is a continuum of grief and loss. There's always going to be grief and loss in our lives. And it may be small, but it's going to be there. Think about childhood stages. As you go, my son hated puberty because it raised so many weird emotions in his body and in his mind, and he was feeling things in his body he did not understand. And he wanted to be a kid again. It was too complex. When I was in medical school, I remember see the movie Never Ending Story. You guys may know that. It's kind of a corny little movie, but it's really about the nothingness of adulthood taking over a childhood. And the child is fighting this. And I just started bawling in the theater because I recognized that my childhood was done. I was now in a world of real disease, really sick people. And it wasn't like fun childhood anymore. So it made me really think about this. But that was a loss for me. I had to grieve a little bit about losing that childhood innocence and moving on. So loss is a part of our human story. Many people just try to take loss and kick it out. Don't even let it be part of their story. But you really need to incorporate it into your story because it's important. A loss of a loved one needs to be incorporated into our story. A baby's story may be limited, but I can guarantee you, like talking about some of these where the pregnancy was going fine, then all of a sudden there was a fetal demise inside the womb. They had plans for that baby. They were putting together a story. So we have to recognize that it is a story. Chronicles of Narnia, there's several books, and one's called A Horse and His Boy. And I love this little interaction because it made me think about this idea of story a little bit more. Shasta is this young adventurer, basically. He's confronted by Aslan, and Aslan is the godlike figure in this. And his buddy, Aravis, was wounded. And so he's talking to Aslan about this. And he says, then it was you who wounded Aravis. It was I. But what for? Child, I am telling you your story, not hers. I tell no one any story but their own. And the reason I bring that up is because I think we so often want to explain somebody's loss in terms of our story. But it's their story. And whether you believe in a God or not, is that God taking them through some story that you're not privy to? So we have to be careful about putting our story on top of their story and recognizing that this may be something that they have to go through as well. We want to help them through that. And I would say, physicians, we're a bit part in these people's stories. I come in, I see the patient for a couple minutes, I talk to the parents for 5 minutes, then you guys are with the family the rest of the day. So I have really a bit part in their story. But you are a supporting cast. So it's not that you're not a part of their story, but your story is not their story. So you really are in a best actor or actress mode. It's really the best nurse in a supporting role. So you are a supporting character in their story. So don't diminish where you're at, but recognize that you didn't drive, it's not your story. There's several things that make it difficult to deal with death, and we've already touched on some of those with some of those scenarios. But death is basically unacceptable in our culture. It's just, if there's a death, immediately we get lawsuits and finger pointing and all that. Death is feared, and very few experience it up close. There used to be a time when people died, they died in their homes, and everybody was around them. It was nothing unusual. It was sad, but it wasn't unusual. Now we've been able to put it into sterile hospitals, in isolated rooms, and nobody has to see it. Parents are not equipped emotionally to deal with it. And unfortunately, our culture says, well, you parents need to make the decision, at least in the case of babies, you parents need to make the decision about your baby. And they're not prepared for that. We know, as caretakers, what the ultimate outcome is going to be, but they don't. And as much as we tell them, all they're hearing is, especially in the case of discontinuing therapy, is they're saying, I'm going to kill my baby. That's all they're going to hear. Because they don't have the big long-term picture. So it's great that we give parents rights and responsibilities, but we also give them stuff that they're not necessarily prepared for. You know, there used to be a time, and you could argue that this was not necessarily a good time in medicine, but the doctor would just come in and say, your baby's going to die, we're going to take your baby off the ventilator, and you're going to hold your baby. And the parent, you could say, well, that's kind of draconian, but you know what? It takes all the responsibility, puts it on the physician, and the parents don't have to think the rest of their lives that I made the decision to discontinue therapy in my baby. So, and I'm not trying to say that that was a glory day of medicine or anything like that, but we have given parents responsibility for things that they're not emotionally prepared for. Discontinuing life support, no matter what you say, is viewed as active. So even though you're just pulling away intensive care, they're going to say, I killed my baby, or whatever. So they have a difficult time with that active and passive type of a situation, okay? So it's something to keep in mind. We tend to see life as a motion picture, but a grieving person may see nothing but a snapshot, and you probably run into people like this in your life. And even maybe for your paramedic father, who for that month, all he saw was the snapshot. He couldn't move forward because it was such a traumatic event for him. And so people are going to focus on that picture, and they're not going to be able to move on with their life, and that can be a real problem. They may blame someone, including themselves. And we see this all the time in neonatal medicine. The mom will say, oh, I took an antihistamine during pregnancy. Did that cause the problem? You know, obviously it didn't. But they're searching their minds to find out, or they're searching their pregnancy history for what did I do wrong. And some of them won't even verbalize that to you, but you need to recognize that that's there and to assure them that this was not their doing, because they're going to blame themselves too, as well as others. But and if you can't let go of that, blaming yourself or others, you're not going to be able to practice forgiveness, and ultimately, you're not going to heal. These are some of just the responses to grief and loss, you know, kind of textbook ones in a sense. Anger, withdrawal, avoidance, you've already talked about some of those. Depression, some people just lose themselves in their work. That's the best way, so they don't have to think about it. communication breaks down. This is hard on not only between caretakers and families, but between spouses. Because the spouses or the family members may have very different ideas about what's happening to their, in my case, in babies. So there can be a lot of conflict. So it's something just to be aware of. You guys are in a unique position because you are at the bedside all shift long. Now it's going to depend on what floor you're on. If you're in an intensive care unit, you're caring for 2 or 3 babies, and if it's a really sick one like this, you may be the sole caretaker for that baby. And the parents are sitting there, and they're going to talk, and you're going to have conversations with them. So you are there all the time. So you're not only caring for the baby, you're caring for the parent. Or if it's an adult, you're not only caring for the dying adult, you're maybe caring for the family. So recognize that it's your responsibility actually goes a little bit further. And parents will confide in the nurses. They'll probably be less likely to confide in me because I come in for my 5 minutes and I talk to them. And I always encourage them if they have questions, they want to talk, I'll do that. I would love to do that. But again, because you've sat there all day long and they've seen you caring for their baby, their parent, whatever, with love, they're going to trust you. And they're going to confide in you. And they'll ask advice too. So you oftentimes can help open up other avenues of support that instead of me just coming in and say, okay, well, you should probably talk to pastoral staff and social worker and stuff like that. You are going to have a much easier time doing that because you can put the whole picture together. So what can you do if you're that bedside nurse dealing with patients in this situation? Establish a presence. Just be there. There's a book in the Bible called the Book of Job, and it's really interesting. Job is a guy whose life is growing great, and then he's afflicted, and all these terrible things happen. Family members die, he gets diseases, things are not going well. And his friends come to him, and they see him, and the first thing they do, though, is they sit with him quietly for 7 days. They don't even open their mouths. Then they start to open their mouths, and then it all goes to hell. Because basically they try to explain, well, this is why this happened to you, Job. This is why this happened to you, Job. So sometimes just saying nothing is the best thing to do. And it's hard. It's hard to do because you want to try to, in a very good way, you want to comfort them. But you have to sometimes recognize that sometimes silence is going to be golden. Listen to the families without judgment because they're going to say things again because they trust you. They're going to say things. So just don't judge them. Encourage them to mourn. Demonstrate love and respect for their baby. Include the parents. Or again, if it's an adult, family members in the care of that person. They've been caring for that person at home, and now in the hospital, we don't want to separate that. They can still very much be a part of the caretaking. Education, because they're going to have lots of questions, they're going to ask you about these disease processes. They're going to say, oh, have you ever seen a baby like this go through this before? What happens? What should I expect? So you're an educator as well. And also the complexities of care. Especially if you're in an intensive care unit, there's all sorts of complex stuff going on. So you are going to be an educator. We talked about this a little bit before. Coordinating care, communicate with the MD. Most of the information I probably get about parents is through the nurses because the nurses will confide with them. And then they'll tell me, oh, this family's really going through this, or they have questions about this. They didn't understand that. Something they may not tell me, but they will tell a nurse. And then memorialize. Again, create a story, put them into the story. And that may include blocks of fare, footprints, significant pictures, drawings by siblings, things like that. All those things can make them incorporate their dying one into the story, or completing the story if it's, say, an adult. Encourage the families to hold their babies as much as technically possible and allow them alone time with their baby. This is one of those things that when parents come back, they're very hesitant to hold a dying baby because they just don't know what to expect. But oftentimes, or more often than not, what we hear is they say, I am so glad you told me to hold my baby, even though they were uncomfortable. Because that is something, that's a human way of giving love or giving medicine, really. And so by doing that, you can say, you've already allowed that parent to be a part of that process. And that's really, really important. You may have to explain the physiological details of death to prepare them when they do hold that baby. And then again, help alleviate unwarranted guilt because they're going to be blaming themselves and others and things like that. Don't compare grief because you could say, well, this family, they're grieving over this minor disease that got fixed, and I have this family over here and their baby's dying. And now you're going to compare their grief and say, I don't understand why they're so bent out of shape. It's their grief. Grief is real to them. If you start comparing them, it's not really fair. Everybody has a different threshold for being able to tolerate grief too. So you need to take everybody's grief seriously, okay? You can bring in your experiences of grief and loss. I think that's going to be really important because that allows you to empathize, and they're going to trust you now because they know you've been through something like that. This last part, but not as suggestions for coping, I have mixed feelings about that because I think you can still offer them helpful things if you say, you know, this helped me, but not in a sense of this is what you need to do. You know, so it more as I think as a suggestion is reasonable, but not as trying to dictate. Well, you should go home and do this, this, and this. I don't think those things work. But if you can commiserate with them, they're going to trust you a lot more. Incorporating them into the story, don't rationalize the situation. It's okay to cry. Like you said, your nerves are raw. I still cry. You can probably sense I'm periodically tearing up a little bit here because it's hard. It's a difficult thing. And it's okay to say, I don't know. You don't have to know everything. I don't know if any of you know who Jerry Sitzer is. He's a theology professor at Whitworth, and he was when I was in the program. Terrible thing happened to him. His family was traveling back from, I think they had gone to an Indian reservation for something, and they came back and they were hit by a drunk driver. And his wife and I think 2 of his kids were killed. Instantaneously, his life was transformed. And if you ever want to read a good book about grief, this is great because it's not a oh well I got stronger through it. He says it sucked, but things did get better, and I did learn some things. So he says my suffering is as puzzling and horrible to me now as the day it happened. The good that may come out of the loss does not erase its badness or excuse the wrong done. Nothing can do that. So it's just a very honest way of looking at it. We can't just gloss over it, and we can't just say, well, you're going to be stronger in the end, blah, 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 blah. And these are some ideas that are from his book. The experience of loss can expand your soul. And for any of you that have kind of gone through suffering, it's really kind of interesting because you almost have sorrow radar. You can pick it up in a room. When people are hurting, you are drawn to them because you want to comfort them because you know that's something that you needed. It increases your ability to love others and to empathize with them, but also it's a risk in the sense because now you're opening yourself up to somebody else's hurt. And you may already have a lot of hurt too. So I'm not saying that you don't do it, but just recognize that you can expand your own sorrow by doing that. But also that sorrow has allowed you to expand to be able to help another too. The pleasure of life is so great that it demonstrates the supreme value of what is lost. This is even more profound with a baby when you think about, wow, they didn't ride a bike. They didn't go to the movies. They didn't see Disneyland. They didn't whatever. You know, there's a lot that they haven't done. So that's a lot of mourning to do in a sense for stuff that hasn't happened as opposed to a life where stuff has already happened. And then suffering unites us in community. As bad as suffering is, suffering unites us. I have Mothers Against Drunk Driving. That came out of a sorrowful experience. Somebody's child got killed by a drunk driver. And now we have an organization that helps others go through that. The Polly Klaas Foundation, where a child was abducted and killed. Well, now we have a foundation for that. So these tragedies spawn universal responses to try to fix that or make it better for others. And I think this is a really interesting concept. There's a writer who I really like. His name is Frederick Buechner. And he talks about the steward of our pain. You know, people said, well, you need to be a good steward with your resources, a good steward with your money, a good steward with this. But nobody ever says a steward of your pain. That's crazy. What happened was that he was giving a talk, and his father and his uncle committed suicide within a relatively short period of time. And he was telling that story, and a guy from the audience said, you've had a good deal of pain in your life, and you have been a good steward of it. And that just kind of blew him away. And this is what he said. I knew that a steward is a caretaker of some kind or other, the person who takes care of money particularly, or real estate, or a stateroom of an ocean liner. But what did it mean to take care with the hurtful things that happen to you? How do you go about being a steward of all things, your pain? Being a good steward of pain involves being alive to your life. It involves taking the risk of being open, of reaching out, of keeping in touch with the pain as well as the joy, of what happens, because at no time more than at the painful time do we live out of the depths of who we are instead of out of the, sorry, I don't know the rest of it. I don't have it down there. But we live out of the depths of who we are. So he recognized that this pain actually can be a gift to others. We redeem suffering. We love redeemed suffering. Superstorm Sandy, terrible devastation. But People magazine knows that if they just tell a story about the terrible storm, that's not very satisfying. We want to know, who are the heroes of the storm? We hear this all the time. What happened perhaps a year later? How are people rebuilding? How's the community coming together? It's suffering redeemed. That's what we love. That's the way we deal with suffering. Or the Boston bombing, the Boston Marathon bombing, same thing. Well, now these people are coming back stronger than ever. We want suffering to be redeemed. So while we can consider suffering a terrible thing, we can be stewards of it, and many people are, and become redeemers of suffering as well. Before I got into medical school, I volunteered at the Columbia Lutheran Home, which is an old folks' home. And it was one of the most amazing experiences. Like I said, I thought I was going to go into geriatrics. This was Chet. This was Grace. These two had Alzheimer's. Grace was always looking for her cat. Chet was always looking out the window, looking for something. We could never quite tell what he wanted. And this gal, she was really pretty with it, but she had other issues. And she was kind of crotchety, but we became friends. And she didn't really like being around these people all the time. But anyway, it was just a profoundly influential experience for me. And one of the things that they did, and I don't know if you can really see this very well, but I will read it to you anyway. When I was done there at the end of the year, they knew I was going to medical school. And so they got all the residents together, the ones that were with it. And the social worker gave me this little poster document thing. She wanted to ask all the residents, what is a good doctor? And this, you can replace this with good nurse, okay? And this is what they came up with. And I just want you to hear these words and then just think about what are they really saying. A good doctor / nurse is a person who knows how to listen and is willing to teach me. One who is warm, friendly, and cheerful looking, a person I can talk with. He is one of whom I am not embarrassed to ask questions of, even ones of a very intimate nature. He is a person who can talk to me, a person who regards me as an individual and an equal, someone who talks in a friendly way in words I can understand, who cares for my spirit and emotions as well as my body, and who considers my financial situation. He is someone who can counsel me and my family. He looks me in the eye, and I know that he is interested in me. He is brave enough to say, I don't know sometimes. He is one who is considerate of patients and staff, even under pressure. Most of all, he is one who recognizes that if he were all these things, he would be a Superman. And I appreciate him as his heaven. I appreciate him as human. A good doctor is one who learns to care for himself as well as he cares for his patients. So, in the standard way we think of physicians and nurses and what's missing from this? What would you say? Not necessarily in a bad way. There's nothing in here about he went to the finest medical school, he got the best residency, he graduated the top of his class. Nothing. They don't care. They want to know, do you care about me? Are you going to look me in the eye? Are you going to work with me through this situation? That's what they care about. So we can all get all concentrating on grades and all that stuff, and you all do. I did. But recognize that they don't care what your grades are. They want to know, do you care about them as patients? And you're not immune. We've been talking about their suffering, but you guys aren't immune, and we've talked about that a little bit already in the fact that these things are going to influence you as well. So you're going to grieve as well. Unfortunately, medicine is not very good at caring for its own. It may take good care of patients, but it doesn't take good care of its own staff. Medicine is quick to point out mistakes, but often fails to say, well done, good and faithful servant. People are going to tell you, oh, you screwed up on this, and this. But very few people are going to say, wow, you were so awesome with that family. Or the way you did that particular procedure was so good. Medicine is all about being stoic, and it's not about being vulnerable. But you need to allow yourself to be vulnerable, because if you're stoic, you're just going to keep holding it in. It's going to come out in some way, shape, or form. And so you have to be able to let it out. Richard Swenson is a physician, and I think this, especially in intensive care, this is very applicable. Progress tricked us into trusting it, and then it exhausted us. Intensive care has gotten so complicated. We have so much data. We have so many fancy machines. We have so much stuff, and it just makes it even harder because it's exhausting. So we can say, yes, these are good. A lot of these things are good, good progress made in medicine, but it's exhausting, especially in intensive care. People that go into intensive care tend to be adrenaline junkies too. They like to live on the edge. You oftentimes see the ICU doctor who has to go out and smoke his cigarettes after he's done with the stuff because he's just, he loves to live on the edge. And I would say to a certain extent I was that way, I'm less so. But the problem is they get so fixed on their own adrenaline, they don't think about the dopamine and oxytocin levels of others, meaning the sadness or the happiness of others. They're so fixated on the procedures. And oftentimes, intensive care docs are so into adrenaline and living on the edge that they're terrible at talking to patients about death because they're in there for the excitement. Death is a failure, in a sense. And so they're not able to walk patients through that. So we have to recognize that, and you guys may be wired that way. You're adrenaline junkies. That's what you want to do, which is great. But recognize that there are other people that need your care and not just your adrenaline. This is my eldest daughter and my son back in the day. She's now 24. He's 22. You may work at a place where new life emerges. 2 enter and 3, 4, 5 emerge. When I first came to Spokane, there was a perinatal or a infertility specialist who was really good, and he was implanting like 5 embryos at a time, and they were all taking. So I was going to lots of deliveries with quadruplets and quintuplets and things like that. So the reason I point this out is that there can be very happy times. 2 parents come in and they come out with a baby. Now 3 come out. Annie Dillard is another writer who I think is really kind of interesting. She spent some time in a newborn nursery and a labor and delivery floor, and this is what she taught. This is how she described labor and delivery in the newborn nursery. There might well be a rough angel guarding this ward, or a dragon, or an upwelling current that dashes boats on rocks. There might well be an old stone cairn in the hall by the elevators, or a well, or a ruined shrine wall where people still hear bells. Should we not remove our shoes, drink potions, take baths? For this is surely the wildest deep-sea event on earth. This is where the people come out. Just such an interesting way of looking at the labor and delivery floor. This is where the people come out. So it can be a very happy thing. But some of you are going to work in adult ICUs where 2 people come in and only 1 leave. And so we have to be prepared for that other side of the coin. You hear about taking your work home with you, and depending on what type of nursing you do, you may or may not. But this is not like taking home papers you have to do or work you have to do or something you have to catch up on. When you're taking your work home, you're taking home the anguish of your patients. And it's something that you're going to need to decompress. And hopefully you have a significant other that you can talk about these things too. If not, certainly colleagues, it's important to be able to talk about those things because you will take that home. You're going to think about those families. And it's not just completing a report or anything like that. It's a much bigger, more emotionally draining thing to do. So here's me back in the day. This is at Deaconess. And this is just excerpts from that thing I read to you earlier. A good doctor is one who learns to care for himself as well as he cares for patients. Most of all, he's one who recognizes that if he were all these things, he would be a superman. And I appreciate him as human. In medicine, we all want to be super people, but you have to recognize we're all human as well and accept that fact. So what can you do? This is amongst you guys, not the patients that are grieving, but what about you guys? Talk about stressful situations. Most good hospitals and intensive cares, if there's a code or an unexpected thing, people come together and start talking about it. It's usually more technical talk. We need to throw in some emotional talk too. Decompress. I think your dad said he's going to have to go away. You have to stay away from things for a while. Lift your eyes up from the keyboard. In this day and age of electronic medical records, which has done a lot of great things, you walk into a ward or intensive care and everybody's like this. There's babies all over the place, there are patients, and everybody's just like this. You've got to lift your head up from the keyboard for a moment and recognize that you're doing something bigger than just entering data. Encourage your coworkers, compliment them on a job well done. Because like I said before, medicine is not going to do that, or it's going to be rare. So if you see one of your coworkers do something amazing, compliment them. You can even hug. And then the last thing is feed the margin. And this comes from a book, Margin, by that guy I quoted earlier, Richard Swenson. And he's a physician that's concerned about burnout. And this has become a bigger deal, certainly in physician circles, I suspect in nursing circles too. Lots of literature and people coming out talking about stress and burnout. And he calls overload is not having time to finish the book you're reading on stress. Margin is having time to read it twice. Overload is fatigue. Margin is energy. Overload is red ink. Margin is black ink. Overload is hurry. Margin is calm. Overload is anxiety. Margin is security. Overload is the disease of our time, and margin is the cure. And what he says, well, I'll kind of outline what he says for you. He considers margin something that we hold in reserve for contingencies and unanticipated situations. So we all go to work. We don't know what the day is going to bring. And I remember many days just walking to the neonatal unit just saying, all right, get me through this day, God, because I have no idea. You just don't even know what you're going to step into. But if you have a margin that you can adapt, then you're going to be able to get through that day. So it's a space between our day-to-day functioning and then our ultimate limits. That's the margin that we build up. Activities and interests that give us a buffer from the mundane and allow us to do our jobs without burning out. You guys are all interesting people. You probably all have great, interesting hobbies that have nothing to do with nursing. Pursue them. You need to have that aspect to build a margin for you, but also to give you just a chance to unwind. If it all becomes about medicine and nursing, you're going to burn out much, much quicker. This didn't quite turn out so well, but this is, I told you a little bit about my story. Well, I've been practicing medicine for about 20 years, and I was developing an interest in theology, and that's all I wanted to do. And medicine was becoming very uninteresting to me. Well, neonatal medicine is just stress. And so once I lost my margin, I loved neonatal medicine, but once this is what I wanted to do, there was no buffer. There was no margin. And I just got burned out. I said, I have to get out because I'm not the person I used to be. And so that's when I made the decision. That was about 9 years ago. And I got out of medicine. And then I actually got my theology degree, as I mentioned before. But now I had theology and a theological interest. So even if that got difficult, I had this buffer, this margin. Sometimes we have to change jobs in order to maintain our vocation. And I had to change jobs. And it was the best 9 years I've ever spent. So here's my graduating with my master's degree in theology. Then I taught 7th and 8th graders. I taught high school students too, but I taught 7th and 8th graders. And I can tell you in college, I remember saying specifically, I will never teach high school students or junior high students, never, ever, ever, ever. And I ended up doing that. Then I actually wrote a couple books because of the spiritual journey that I was on. And so I did some stuff that I never would have done. 20 years ago, if you just said, oh, you're going to write a book, Eric, I would have said, you are crazy. I didn't like adjectives. I could barely put 2 words together. But because of my passion and everything I went through in that theology program, I was able to write. Now, I actually have a job where I work 7 days, so 24 hours a day, 7 days a week. So it's pretty intense, but it's mostly newborn stuff, so I don't get that many phone calls. I get called in some, but not that much. So it's doable, but then I have the next week off. And so I can do my theology interest then. I can write and I can read. And it's just such a nice balance because I'm doing things that I love to do. And it's created a balance in my life. Now, I'm not going back to the intensive care. So I had to make that decision. I could make more money by taking care of really tiny, tiny babies in the middle of the night. But I know that's not going to give me balance at this point in my life. And then this is the most recent book I wrote too, which it's my way of looking at this connection of spirit and material. This is it's really from a Christian perspective of how I understand the physical and spiritual being put together. And I just throw that out there. I've got books here. You can take one if you'd like. Please feel free to take one. If you don't feel bad if you don't take it. It's no big deal. It's a short little book. But if you're interested in some of the stuff that goes through my brain, it's not all about medicine. A lot of it's theological as well, but it does bring up a lot of medical examples as well. And in the end of all of our exploring will be to arrive where we started and know the place for the first time. So I had to kind of journey away and come back to know that I was right back where I started, but now I understood where I was because I lost so much of that in stresses of the intensive care. Much of our human unhappiness stems from the fact that an artificial wedge has been driven between material and spiritual unity, and that's changing. People now are much more open and honest about spirituality, and although organized religion is becoming diminished, people are still as spiritual as ever. So, which is a good thing. So we need to recognize that the two are connected. And I think, in my mind, man's going to be unhappy unless we successfully bring those together. So what have I learned? Tell those around you, appreciate them. You may never get another chance. My dad, when he was a young kid, he was a bit of a firecracker, which is actually kind of funny considering the story. When he was young, he put a firecracker underneath a glass jar, lit it, and he wanted to watch the glass jar blow up. And of course, it didn't go off, so he went up there to look at it, and then it exploded. And he got some glass embedded in his eye, and it got really infected. At that time, there was no antibiotics, so they took him up to Minnesota. And the physician there actually did fever therapy. So he induced fever. He injected toxoid into my dad's body so that he would develop a fever response, because fever is what actually does kill bacteria, treats disease. So he had this fever therapy. But the doctor that was there, because he knew my dad was a young kid, this doctor told his parents to step outside. And so he had brought my dad in, and they filled up big syringes with water. They went out to the doctor's window, and they were squirting people in the street. My dad was immediately trusted this guy, because this guy was a bit of a rapscallion himself. But he had a relationship now with this physician, because this physician did something just so out of the blue, so out of the ordinary. And my dad never got a chance to thank him. And he went back and tried to find this guy, but he could never find it. So you may never get another chance. So tell people you appreciate them. Despite electronic medical records, you still have a heart of flesh. Create and foster margins in your life. Recognize when your margin is slipping away. Reconcile the spiritual and physical. And recognize that others oftentimes have the threads that are going to complete your life tapestry. So if we're weaving a life tapestry, other people are bringing in threads to fill that in too. So allow them to incorporate those. Kind of that supporting actor thing. Nurses are amazing. You guys make us look good. I mean, if I'm liked as a physician, it's because of the nurses. Because they build me up, they give me information, they make me a better physician. You provide the counseling when I drop a bad news bomb, because usually they're so stunned they don't have any questions for me, and then they spend the whole rest of the time talking to parents. You're the love providers when the parents aren't there. You are loving that baby while they're not there, or the adult loved one. You lift each other up. You facilitate redeemed suffering like we talked about before. You're facilitators of redemption. We think of servants. We think of firemen and police women and military guys, but you guys are servants. You are serving. And I love this quote by Albert Schweitzer. He was a physician who actually spent a lot of time in Africa taking care of people. I don't know what your destiny will be, but one thing I know, the only ones among you who will be totally happy are those who will have sought and found how to serve. So your ability to serve is going to be a source of happiness. It's going to be hard too, but that is what's going to make you happy. And this is my wife, by the way. She was in Mexico when they had a big earthquake in the late 80s, and she went down there as relief. So she, outside of her normal neonatal job, she went down there and served as well. That's why I love her. That end. Thank you very much for letting me speak, guys. I hope that this was of some help to you, maybe made you think a little bit. Any questions that I can answer for you or thoughts?